Good afternoon, ladies and gentlemen. My name is Sarka Tesarova. I work at the third department of internal medicine of General University Hospital in Prague, Czech Republic, and today I would like to share some data about lipodystrophies with you. Lipodystrophy generally occurs in 1 to 5 patients per 1 million. It is a heterogeneous group of diseases. Typically is generalized or partial loss of adipose tissue. Because of that, the storage capacity is decreased and it leads to ectopic fat accumulation in liver or muscles, and loss of adipose tissue also lead to decreased level of leptin, which is connected with hyperphagia, decreased insulin sensitivity, and decreased fatty acid oxidation. All of these changes cause metabolic abnormalities such as insulin resistance and diabetes, hypertriglyceridemia, and hepatopathy. Leptin has both central and peripheral effects in the body. It affects feelings of hunger, food intake, and energy expenditure. Leptin binds to neurons which express leptin receptors. Its peripheral effects are suppression of glucose production by the liver, inhibition of insulin production and secretion. It also promotes glucose uptake and metabolism in skeletal muscles. Leptin also promotes fatty acid oxidation in liver, skeletal muscle, and adipose tissue. Lipodystrophies are divided into congenital and acquired forms. Both of them could be generalized or partial. In congenital generalized lipodystrophy is lack of adipose tissue apparent already in newborn children or in early childhood. In acquired generalized lipodystrophy, there is loss of adipose tissue in childhood or in puberty. In both of them, there are severe metabolic abnormalities. First symptoms of partial lipodystrophy are seen in puberty or in early adulthood. The severity of metabolic abnormalities varies. In family partial lipodystrophy is loss of fat from the lower half of the body, meanwhile in acquired partial lipodystrophy it is from upper half of the body. Prevalence of generalized lipodystrophy is 0.2 to 1 per 1 million. It could be familial with autosomal recessive inheritance. There are 4 types. Common for them is almost total absence of adipose tissue since birth. These children have prominent muscles and veins, metabolic abnormalities such as severe hypertriglyceridemia, insulin resistance, hepatosplenomegaly, cardiomyopathy, and acromegaloid features as well. In acquired generalized lipodystrophy, there is association with autoimmune diseases such as juvenile dermatomyositis or hepatitis. Familial partial lipodystrophy is the most common type with prevalence 19 to 30 per 1 million. There are a lot of genes whose mutations could cause FPLD. The most frequent type is autosomal dominant. Also, several progeroid syndromes and autoinflammatory syndromes are associated with partial lipodystrophy. Acquired partial lipodystrophy is in association with autoimmune diseases such as systemic lupus erythematodes, dermatomyositis, or Sjögren syndrome. The symptoms of FPLD are connected with partial loss of adipose tissue. These patients have ectopic fat accumulation, hepatomegaly, liver steatosis, fibrosis, or cirrhosis. Frequent is cardiomyopathy, metabolic abnormalities such as insulin resistance, prediabetes or diabetes, and hypertriglyceridemia, which can lead to pancreatitis. There could be also hyperandrogenemia with hirsutism, oligomenorrhea, polycystic ovary syndrome, and nephropathy. Now this is a case report about my patient with FPLD2. It is a female born in 1996 and her first symptoms have occurred when she was 25 when dilated cardiomyopathy was diagnosed, as well as hypertriglyceridemia, hepatomegaly, and liver steatosis. During next year and a half she had several cardiac complications such as implantation of biventricular ICD for frequent ventricular extrasystoles. Later she had radiofrequent ablation of supraventricular tachycardia, and also apixaban therapy was started because of paroxysmal atrial fibrillation. Patient was also diagnosed with pulmonary hypertension and treatment with sildenafil was initiated. She also had mitroclip implantation because of significant mitral regurgitation. Finally, after 2 years from initial symptoms, she received result of her genetic testing. There was described mutation of gene for lamin A, which causes familial partial lipodystrophy type 2 and atypical progeroid syndrome. My patient's variant is very rare. It was described just in a few patients around the world. The most impaired organs are heart and kidneys. Often there are dilated cardiomyopathies, arrhythmias, valve diseases, loss of fat from lower limbs, and ectopic accumulation leads to hypertriglyceridemia and steatosis. There could be also premature atherosclerosis and hearing loss. This mutation also causes atypical progeroid syndrome, with symptoms overlap with partial lipodystrophy. In addition to that, there are also progeroid features such as short stature, mandibular hypoplasia, micrognathia, or big nose. In March 2024, I saw this patient for the first time at our outpatient lipid clinic. She had normal BMI. There were specific symptoms such as hepatosplenomegaly, progeroid features, and thin lower limbs. She was dealing with abdominal pain and irregular menstrual cycle. Her total cholesterol at that time was 3.3 millimole per liter. She had hypertriglyceridemia, almost 5 millimole per liter. Despite her fenofibrate therapy, and LDL cholesterol was 1.3 millimole per liter. She had prediabetes and proteinuria 7.2 gram per liter with protein to creatinine ratio 0.5. Her glomerular filtration rate was normal at that time, and elastography shown hepatomegaly and steatofibrosis in the zone of more severe fibrosis. In April 2024, her cardiologist stopped apixaban therapy. Unfortunately, just 1 month from that, she had sudden onset of aphasia and right side hemiplegia. When T-type left ICA occlusion was found, she had bridging IVT and mechanic thrombectomy with complete recovery. And echocardiography, there was described small fluttering formation on the mitroclip, fluttering towards the left atrium. Because of that, apixaban therapy was reintroduced. We sent her to the renal biopsy because of her proteinuria was getting worse, and there was found focal segmental glomerulosclerosis, which is quite often seen in FPLD2 patients. Her leptin level was in a reference range, but adiponectin was lower. Important fact is the normal leptin level doesn't exclude lipodystrophy. Level is changing during the day, and also reference ranges varies among different labs. We consulted Professor Akinci from European Consortium of Lipodystrophies, and he recommended metreleptin therapy. We have sent a request for her insurance company, and they approved it, so our patient was the first one treated with metreleptin in the Czech Republic. Metreleptin is causal therapy for patients with lipodystrophy. It is recombinant analog of human leptin. Patients administer it daily by subcutaneous injection. It mimics physiological effect of leptin. It improves hypertriglyceridemia, insulin resistance, and also hyperglycemia. Indications of metreleptin treatment in the European Union are generalized lipodystrophy from 3 years old and partial lipodystrophy from 12 years old in patients who didn't achieve sufficient metabolic regulation. There are around 500 patients treated with metreleptin worldwide. Here are results. After 7 months of metreleptin therapy, triglyceridemia level was reduced by 43%. Her proteinuria was better. She has lost weight, and also her glomerular filtration rate was better. She described decreased appetite and regular menstrual cycle. If you have suspicion to lipodystrophy in your patient, I recommend to go to website of ECLIP, which is European Consortium of Lipodystrophies, and try to find a center for lipodystrophy in your country. Otherwise, you could ask through the form on ECLIP website for consultation of your case. Thank you for your attention and have a nice day.